Welcome, everyone. Thanks for joining us today. My name is Mary Jo Katris, and I'm with University of Minnesota Extension in the Center for Family Development. And we are excited to be hosting this webinar today and around medications for opioid use disorder, talking with clients, families, and colleagues about facts versus fiction. And this funding for this webinar comes from a grant, a Rural Opioid Technical Assistance Grant that's funded by SAMHSA to support rural communities in around technical assistance around recovery and substance use. And Minnesota is part of one state within this partnership that includes Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin, who is leading the charge for us. And so we are excited to be able to bring all of us together to learn and share resources amongst our states in our region. And again, when we are doing this work, we all know that words matter. And so we just like to have this slide here just to remind folks of that words do matter, that we focus on person first language when we're talking about behavioral health disorders, that's non-stigmatizing, recovery oriented, and promoting successful engagement in treatment and recovery. So we always just like to have this slide just to remind folks of the values and the focus of our work and supporting those in recovery and in their journeys. So I'm going to turn it over to Dr. Carrie Hager, who's going to lead us in our discussion today.
Thanks so much. Welcome, everybody. I'm very glad to be here with you today. And just a call out from the previous slide, if you do hear me using language that is not person first or that you have suggestions for improvement, please call me out. You can chat it in or unmute because I'm always trying to learn as well. So I am Carrie Hager. I am faculty at the University of Minnesota at our College of Pharmacy. And as part of my role there, I do practice as a pharmacist 2 mornings a week. And that in the last 3.5 years has been with the Center for Alcohol and Drug Treatment in Duluth, Minnesota, where I meet with folks to help identify if they have any medication related needs that I can help them with to make sure that they're reaching their goals and they're only taking medications that are working for them, they're not having side effects, and that we coordinate to help them reach their goals. And if you haven't yet, if you don't mind putting in the chat who you are, what your role is, that kind of helps us understand who our audience is. I want to acknowledge there are several colleagues that have contributed to this presentation, and this presentation continues to evolve after every time I give it, because I learn from so many people that participate in the dialogue that we have. I want to recognize all of you for joining us today and the expertise that you bring to help shape this as well. And of course, the funding to make this available. I really want to present today, but I'm informal. So if there's something you want to chat about, you can chat it in and I'll get to it. Or if you want to talk about something at a given point, I'm happy to be interrupted, and hopefully we can still get through the whole presentation. But I really want to make sure that we're addressing the things that are important to you so that you can feel like you leave this webinar today learning what you came to learn and find something useful that you can use today. So I am going to do a few polls. This is the audience engagement part, right? So I just want to kind of get a pulse on what folks know or what your understanding is of medications for opioid use disorder. Sometimes you'll hear it as MOUD, or you'll hear MAT, medication assisted treatments, kind of older language. And what I'm talking about are methadone and buprenorphine, or the brand name Suboxone type products. So I'm going to put a poll up. This is completely anonymous, so feel free to answer honestly. But what is your understanding? Is it complete? Can you teach others? Do you know quite a bit, but you have some to learn? You don't know, so that's why you're here. Or you think it's just terrible? Just get a pulse on where we are. All right. Go ahead and end that in a couple of seconds here if you want to put in your response. Great. I'll go ahead and share those results with you. Looks like we're kind of a mix between I have to stop sharing because the way my screen is, I can't get rid of the poll. Here we go. Pardon me while I get back to the slide. Looks like we have quite a mix up. I know a fair amount, but I have more to learn, kind of like most of us, or I don't know much, and that's why I'm here. So hopefully we can all take some things away from this. And certainly if you do know a fair amount of it or have experience to share, would welcome you contributing your expertise and experience as well as we move along, either through the chat or you can unmute yourselves. The goals really are to describe the medications used for opioid use disorder, summarize very basically the research supporting its use, talk about the stigma that prevents adequate treatment for opioid use disorder, and really importantly, leave today with some new ideas about how we can talk with our clients, patients, family, friends, colleagues about medications for opioid use disorder and make sure we're providing accurate information and we can help dispel some of the myths and misconceptions that are out there. So I always like to start with a story. I have a brief video. It's about 6 minutes long that I'm going to share. And this is a colleague of mine, a family medicine physician, and one of the patients that she worked with, who was started on buprenorphine or Suboxone medication for opioid use disorder, along with a treatment program as well, describing her experience. And I think this really lays the foundation of how these medications can work for people and highlight some things I want to bring up later when we get into the myths and misconceptions. And sorry for the back and forth. I'm on this laptop and there we go. I think I need about 5 more hands and a couple more computers. Okay, if someone can let me know if you can hear this once I hit start, that would be great.
I just wonder if you could tell us about your life before treatment.
I started opiates when I was in college, and it was just, you know, kind of like once a month use with a girlfriend, my roommate actually, and then we started doing it a lot more, but then we would stop and all of a sudden it's like we would have these withdrawal symptoms. At the time we had no idea what withdrawals were, that we could become addicted to, our bodies would become addicted to something. I stopped for a couple years. I was still drinking, you know, so I wasn't completely sober, but then I started back up again in my late 20s. I started using heroin probably 27 or 28. I mean, I was addicted full blown at that point. You're a slave to this drug that has completely taken over your life and you as a person. You're no longer, you're lying. I didn't know how to get help and I didn't want it. I didn't know what my life would look like sober, and being an addict, period, it's like we're digging ourselves our own holes, because the shame and guilt for me personally was a lot of, well, I'm already lying, I'm already using, my friends already know, my family knows, like, you know, I'm just gonna keep using to numb that, and it's just like this vicious cycle. I was getting down to my very last bit of heroin, and my mom had actually opened the door, and I was just out of it, but I was trying to shoot up, and she walked in, and it was like there was no hiding it. She already knew, but she didn't know to that extent. And I went to Marty Man, I think it was 2 weeks or 3 weeks later, and I got in and I had to go through detox again because I was under the influence. And once I got there, it was probably 2 weeks later where I was able to see a doctor for to get on the Suboxone program.
So can you tell us then what it's like transitioning to Suboxone and how you feel on that and how your life is now?
The program, treatment, and Suboxone saved my life. I do feel like that is the truth, because I don't want to say it was just Suboxone or it was just treatment. Treatment gave me the tools and the resources in this area and within myself to be strong enough to overcome addiction and why I used. I wasn't sleeping. I was extremely uncomfortable in my own body, and It mellowed all of those withdrawals, but it also, and I still wasn't comfortable. You know, I still wanted to use when I was first taking Suboxone, even though my urges weren't as strong. You know, so I look at my life now and then how it was before, and I have had someone who has said, you know, you're basically just, you're still using a substance, and I quickly was just like, yes, I am, but I'm also a completely different person than who I was when I was using. You know, I would not work 7 days a week and have an animal that relies on me. I would not have strong relationships with my family, with my friends. So it hurts when someone says something like that. But I also see where they're coming from, because it is something that I take every day. And, you know, people can abuse it, and they do abuse it. I feel like if it's used properly, it can save a client's life, a patient's life, a person's life. I'm honest with my family. I'm truthful with myself, with therapy, with friends, with counselors, doctors. With Suboxone, you know, when you initially take it, it calms everything, and it clears your head, and it stops those withdrawals. And at that point, if you really do want help, that's what you want it for, is to get rid of the withdrawals, and so you can think and concentrate, and then you know, once you stay at treatment, or whether you're an outpatient or inpatient, you know, there's a lot of people there to help you and support you, and you get relationships back, and relationship with yourself back, and I think it helps. It definitely helps you do that.
So just wanting to take a moment to pause and think about that, and how does Kat's story compare to maybe what your understanding of medications for opioid use disorder, in her case, buprenorphine or Suboxone, you know, what's your experience? What's your bias that you come to this with based on your experience? And is this different or similar to what you've seen in the past? You've probably seen some sort of graphic like this that talks about the opioids. And just to be clear, when I say opioid, that's the umbrella term for all opioids: prescription, non-prescription, or illicit, legal, illegal substances. So it's an umbrella term that includes things like Loratab or hydrocodone or morphine or heroin or fentanyl or synthetic fentanyl. All of those things are opioids. So that when I use that term, I'm using it as an umbrella term. But we had this first wave of overdose deaths with the rise in prescription opioids and opioid use. And then as those restrictions in prescribing came into play, then we saw the second wave in this rise of heroin overdose deaths. And now we're in this third wave, where we're really seeing folks that are, if they do have overdose or overdose death, that it frequently includes or is caused by synthetic opioids, like fentanyl type products. So you'll probably hear about that in the news. Fentanyl or fentanyl analogs is another thing they say. And because they're ultra potent, they're more likely to cause an overdose death if someone doesn't know the dose that they're getting. And just a reminder to myself and others too, that when we talk about these numbers and these statistics, that all of these are individuals, sisters, brothers, neighbors, and people that were loved, hopefully. And so that we keep that in mind as we're having these conversations. So what is opioid use disorder, or opioid addiction? It's really just a use of an opioid. It can be a prescription, non-prescription, that is compulsive, dangerous, or both. And it's not a weakness or moral failing, and it can affect anyone. And so one of the sort of practical models that we use in treating an opioid use disorder is sort of this chronic brain disease model, and we'll talk a little bit more about that. And it's not a perfect model, but it can be really useful when we're working with folks to help them understand what an opioid use disorder is. So what is addiction? It's really a chronic, relapsing, or recurring brain disease characterized by the 3 C's. Is kind of how we explain it more simply as craving, compulsive use, and use despite harmful consequences. So in a nutshell, it's craving, compulsive use, and use despite harmful consequences. That is what addiction is, and that it's really a complex disease. When we think about it, one way to think about it that can be helpful is to think about how addiction hijacks this reptile part of your brain. That's the part of your brain that you can't control by your thinking, right? It's the one that helps us survive. Our biological survival systems live there. And when you are having an addiction to an opioid, you get this abnormal drive to use, and that you're unable to feel normal or function normally without using. And so when we talk about medications for opioid use disorder, and you heard Kat say this, it cleared her head. So then she could think, cleared her head, and she could participate in treatment and some of the different behavioral interventions around that. So when you think about opioids specifically, and we talk about medications for opioid use disorder, that's really helping us in this reptile brain so we can get into these social, psychological, and spiritual cognitive realms, and even begin to think clearly, because we get that taken care of in our reptile brain. So sometimes that helps folks to understand it. And just also reminding folks, it's really not a simple cause. When we think about addiction in general, there is going to be agent, or the drug or the medication itself has certain characteristics, and how it either creates dependence or not, how it affects the body when it's used. So the agent itself, alcohol versus an opioid versus methamphetamine or whatever it is, what is it? The host, so the individual, what are their genetics? What are they made up of? And how does this agent interface with that? And then very importantly, the environment that the individual is in, that context, that ecology that this happens in. So it's really the overlap of those 3 things, that it's not, a cookie cutter thing, and it is complex, and it includes all of those things, which vary from individual to individual and community to community. And so besides the 3 C's, what are the symptoms of an opioid use disorder? I really want to highlight this part because this can be a little bit confusing. So there are 2 criteria when we're diagnosing an opioid use disorder. One is tolerance. So that's needing more of the drug to get the same effect. So maybe 1 milligram was enough before, but now you need 10 milligrams for the same effect. So tolerance. And then also physical dependence, where your body actually changes such that you're only functioning normally in the presence of the opioid. So both tolerance and physical dependence are part of the diagnosis of opioid use disorder, but they then of themselves are not, right? These are expected for somebody who uses opioids chronically, for example, for pain. They would develop tolerance and physical dependence from chronically using opioids, right? So just having physical dependence doesn't mean addiction. So I want to clarify that, and we'll talk a little bit more about that as we move forward. These are expected with chronic use. This is a really helpful, my colleague, the former chief medical officer, Ferris Keeling at CADT, drew this on a napkin for me years ago, and it just changed my whole thinking and understanding of addiction, because this is not what we hadn't learned all of this back in school when I went through. So I thought this was really helpful to draw out. Here we have on the y-axis how someone's feeling. So like euphoric or high, happy, okay, sad, dysphoric. And then as time goes by here on the x-axis. And so for, most of us, if we have a healthy brain, healthy mind, we have this sort of normal variation in mood, some highs and lows, but kind of around that baseline level. And if maybe we intermittently use a substance and we don't have a susceptible brain to addiction, remember we talked about different hosts and genetics and various factors that play into that. But, maybe we use once, get high, maybe have a little dip or a hangover, and then go back to baseline and can go a period of time without use, right? Use again, get high, maybe have a little hangover, and then move on back to baseline. However, if we have a susceptible brain, and then we're using over time opioids specifically, I'll talk about in this case, you can transition into addiction, where over time that high or that euphoria gets lower and lower, never quite reaching that same level, and the dysphoria or the withdrawal or the bad feelings increase over time, to the point where your brain has changed so much that you're in this dysphoric state unless you have the drug or the medication to get you back to baseline. So using just to feel normal, to clear your head, to be able to think, to be able to function, because your brain has changed from using that opioid over time, that you're no longer getting high, you're using just to feel normal. So I think that's important to think about, that your brain actually changes such that you aren't feeling normal and functioning unless you have the substance on board. And so when you're in that dysphoria, in that withdrawal, so you're not using an opioid, what happens? How does that feel? So this is people feel all sorts of horrible things. Basically, I think of all the fluids, sweating, runny nose, vomiting, diarrhea, craving, feeling just restless, irritable, very uncomfortable, shivering, pain. And when we talk with folks, they describe it as feeling sick. They feel very scared, vulnerable, and literally like they will die if they don't use. It can be pretty significant for people. And so again, at this point, folks are just using to feel normal. And yeah, they can overshoot that and feel high as well. But frequently just trying to be able to go to work, or trying to be able to take care of their kids or do their day-to-day function. So they're using just to feel normal, which is why medications for opioid use disorder can be helpful, because it can help us get folks out of that withdrawal and back to baseline so that they're able to function and participate in life and other behavioral interventions that would support their quality of life. And just a reminder too, this is not like a technical time frame. So you see there's no specific years, but just, addiction to a variety of substances can cause profound brain dysfunction that recovers very slowly over time during abstinence from the substance. And we're not talking days and weeks, we're talking months and years for people, depending on the substance. And so I think when we're working with folks who maybe are early in recovery or cutting back, just helping them understand that, the time factor and how challenging that can be for people as well. This isn't a quick turnaround for people that have been using for significant periods of time. It can be a quick turnaround from how bad they feel, but it does just take some time to recover. And I think like for alcohol, as an example, I think it's like roughly around 2 years for someone who had previously been chronically using alcohol. So the other thing I like to point out is, like, would you stop if you were like experiencing no enjoyment in life without the drug? You only feel normal when you have it. You sort of have this automatic behavior that you can't control. You're feeling impulsive, you're feeling vulnerable, and maybe you don't, it just kind of feels like everything sucks. And you have access to instant, reliable relief, albeit short term. You're going to feel better if you use versus getting into what I'll say, getting into recovery or getting into the supports, which we all know most likely there are a lot of barriers and paperwork, and where do you go, and are there beds, and is it what I need, and have I been traumatized by some of these systems in the past? So you can see why for people, if they have the drug readily available, it's no surprise they would use to feel better when you're feeling that terrible. So my goal, like one of my dreams, would be like helping get into recovery services, whatever that looks like for an individual, would be as easy or easier than going back to use of a substance they're getting through alternate channels that may be contaminated with something more dangerous for them. So just again, reiterating what dependence is versus addiction. So when we talk about dependence, it's over time. With chronic use, your brain adapts such that if you don't have the drug or the medication on board in your body, you're in this withdrawal zone feeling terrible, and that you're needing that medication or drug just to feel normal. That's dependence, which is a component of addiction, which we talked about the cravings and the use despite harmful consequences. I think this can be really helpful when you're trying to help people understand what medications for opioid use disorder can do. So I think it's important to note that it is very treatable. Medications for opioid use disorder, or medication assisted treatment, MOUD or MAT, you'll probably hear both used for a number of years, is using medications plus counseling behavioral therapies as this whole person approach to the treatment of opioid use disorder. And here's kind of like the summary slide of all the research. Why do we use medications for opioid use disorder? aren't, as you heard Kat say, aren't we just substituting one thing for another? Well, yes, in fact, we are a medication. And by doing that, research has shown consistently that we can reduce opioid use. We can reduce opioid overdose deaths, pretty big outcome. We can actually reduce criminal activity. And the data on these slides are about methadone and buprenorphine, not naltrexone, which is the injectable Vivitrol. And we'll talk about that a little bit later. So here I'm really focusing on the methadone and buprenorphine, but reducing criminal activity, reducing infectious disease transmission, and not only all of that, we save money. So that is huge, all while increasing the social functioning of the individual who's getting treated, retaining them in treatment services, and helping them actually be able to access the services that they need to improve their quality of life. And so it's referred to as harm reduction, but I would argue that really maybe even that's stigmatizing, because I think all of medicine is harm reduction, right? We're always trying to help people have a better quality of life. We're always trying to help people meet people where they are and help them reach their goals. And it's not going to be perfection all the time. And it's always going to be a little different for each individual. So it's called harm reduction. I think I don't know. We'll see where that language goes. Harm reduction can be a lot of things. And I think, again, all of medicine is harm reduction. It's trying to minimize harmful effects and rather than ignoring or condemning them. Other things that people might consider harm reduction, providing sterile equipment like syringes and needles for folks to reduce their risk of harm, providing naloxone or Narcan, which is the opioid reversal agent to help people breathe if they've overdosed, are some other approaches. Fentanyl testing strips, so people can test their drugs to see if it has fentanyl, so they don't think they have one thing and then they have another thing. So there's a variety of different options for harm reduction. And I just want to reiterate, opioid use disorder is not a choice or a moral failing. And it's not something you can just manage one time and whoop, you're good, right? It's a chronic relapsing condition that's treatable long-term. And I do want to mention, this is another thing I use as an example when we talk about relapse or return to use and about people being at goal. So I remember when I first learned that, I'm like, oh, relapse is expected or return to use is expected. What? It's not this big failure, right? I didn't know that. That's not what I had been brought up with in my training. But when you think about it, and you think about chronic conditions where you have goals of therapy that you're trying to achieve, like if you have diabetes, you want your blood sugar average to be less than 7% for your A1C, right? Well, guess what? The rates of not reaching those goals for folks with addiction compared with like diabetes or high blood pressure or asthma are roughly the same, right? In that 30 to 70% where people aren't always achieving their exact goal, right? It's the holidays, it's stressful. I got tired of, injecting my insulin and tired of measuring my sugars, and I was eating some sweets and my in-laws were over and yada, yada. They don't come in and we don't tell them, hey, your diabetes isn't perfectly controlled, so we're taking away your insulin and get out of here and good luck, right? That would be out of the question. We'd find out what's going on. What do you need? Do we need to adjust your dose? Can we simplify your regimen? Do you need some behavioral support? Would it help to meet with the dietitian, right? So you meet people where they are, find out what happened, and then see where we can go from there so they can meet their goals. So I think it can really help to think about it as that sort of chronic disease, not asthma. Another example, sometimes people feel great on asthma, so they quit their inhalers, right? And then maybe they get a cold or they get COVID and they end up in the emergency department because they can't breathe. We don't say, oh, you quit using your inhaler, good luck, get out of here, right? No, we help meet them where they are and get the medications they need, get them stabilized, and then send them on their way and follow up them. That's the other thing about this chronic piece. We don't get people to go with their diabetes and then just say, have a nice life, good luck, right? We still check in every 6 or 12 months or more when things maybe aren't at goal to help make sure that people have what they need. And so I think it's helpful to think about addiction in a similar way, that this is a lifelong thing, and maybe it's only once a year at some point, but maybe it's every day or every week in the short term while people are stabilizing on whatever it is. So I think that's really important. The other thing I'll point out is that we frequently see folks that are using more than one substance, or maybe they think they use one substance, but it's actually, contaminated with another over time. So if somebody is being treated for their opioid use disorder, but they're using methamphetamine or they're using cannabis or something else, that doesn't preclude them from getting treatment for their opioid use disorder. We can treat their opioid use disorder with buprenorphine or methadone, and then work on their goals around their other substance use as well. It doesn't mean, oh, we're going to cut you off from your opioid use disorder treatment because you have another use disorder. Just like we wouldn't cut you off from your diabetes treatment just because you now have high blood pressure, right? We work with you over time on all of these things, and we don't cut off your medication for one condition because you have another going on. So I think that's important to note too. This is a slide that's I just wanted to talk a little bit about how these medications work. You have these opioid receptors in other parts of your body as well, but focusing on the brain where addiction develops. And so methadone, buprenorphine, or the Suboxone type products, and naltrexone, or the injectable Vivitrol, they all work on that same receptor, but they all work in slightly different ways. And so I just wanted to explain that methadone, just like any other opioid, would sit on that receptor and cause full activity, but it's long acting, can be used for just once a day and stay in the body a long time, so you don't get the peaks and valleys. So it sits on that receptor and activates it. That's in contrast to that, the buprenorphine is what we call a partial agonist. So I think about it as a partial effect. So it sits on that same receptor as any opioid and has a partial effect rather than a full effect. So there's some safety implications to that, right? It's you're less likely to overdose using that because it's just that partial activation. And then naltrexone or Vivitrol sits on that same receptor and does the opposite. It actually blocks that receptor, similar to Narcan or naloxone. So if you do use it, the opioid wouldn't get to that receptor because it's blocked. So the thing to note about all of these medications that are important is that methadone can be started as somebody is stopping use of other opioids. Buprenorphine, you have to actually wait till they get into withdrawal from whatever they were using, heroin, fentanyl, other opioids. They have to get into withdrawal because buprenorphine or Suboxone is super sticky, and so it kicks anything else off those opioid receptors. So if you're on a heroin and it's fully activating that receptor, and we give you buprenorphine, it'll kick that heroin off and give you partial activity, and that kind of has a similar effect if you do it too soon to giving someone Narcan or naloxone, right? So they can actually have what we call a withdrawal or precipitated withdrawal. So you might hear stories of people like, oh, I'm not ever using Suboxone. I tried it, I got sick. So we have to be careful about how we start the Suboxone so that it goes well and people get the help they need, but don't get sick from it. And we can talk a little bit more if people have questions about that, but that's why we have to be a little bit careful about how we start that one to make sure we don't put someone in withdrawal. They have to start to be in withdrawal, and then we give them doses to get them stabilized. But if we give them too much too quick, they can actually have withdrawal from the buprenorphine. And then the naltrexone or Vivitrol, that's the monthly injection version that we have. People have to be completely off of opioids for a period of time and completely through withdrawal to start that medication because it will put you into withdrawal. So there's some folks that maybe don't want to use or cannot use buprenorphine or methadone that would elect to use Vivitrol or naltrexone as their option. One thing Kat said in her interview that I wanted to point out was that she had to go through detox and then didn't get started on buprenorphine until weeks later, and that's no longer the case. As soon as someone's in the office or they come to withdrawal management, they can get started as soon as they're in withdrawal and have that managed. There's no reason to wait to do that. So I just wanted to be clear about that as well, which is why we're working on getting access to this like out of the emergency department. So if someone has an overdose, they have it reversed rather than going to use again, hopefully we can help them get on buprenorphine to stabilize them so they don't feel like they need to use because they would be more stable on that buprenorphine right away and they wouldn't have to wait for that type of treatment. So again, why medications for opioid use disorder gets you out of withdrawal back to baseline. And that we really, tell people, this is a quote from a physician in Minnesota about, it's a blood pressure med, it's helping your brain function. So really trying to destigmatize using a medication because of the effectiveness it can have for people. And like you heard in Kat's experience, she has these trusting relationships, she has a job, she has her taking care of her animals. And we see this all the time, working with folks who use methadone and buprenorphine, that, you know, they're back in school, they have their kids back, they have a job, they have increased quality of life in any number of ways. And it is really remarkable how helpful this can be for individuals. Okay, I'm going to pause there because I've been talking a lot. I do have just some polling questions, but I wanted to pause to see if you all had questions or anything you wanted to add before we do that. I can't see you, so I don't know if you're awake. Let's see if anyone has their camera on. Like talking into the void. Oh, I'm getting a wave. Thanks, Jen. All right. Well, please chat in or unmute yourself if you do have questions. We're going to do some more interactive pieces here. Again, this is anonymous. We'll go through the polls and then we'll kind of go through the responses afterwards. So some common misunderstandings I hear. Well, let's see. Hopefully I can make the polls work with my screen share better this time. I need a bigger screen. Okay. Medications for opioid use disorder should be offered to pregnant individuals who have opioid use disorder. So the response there, of course, I'm not sure, or this is a terrible idea. Let's see if I can. Mary Jo, is it possible for you to launch the poll?
Yeah.
Awesome. That would really help me because for some reason, it's like it's too big to fit on my screen. So should medications for opioid use disorder, methadone or buprenorphine be offered to pregnant individuals with opioid use disorder? Of course, I'm not sure. This is a terrible idea.
I think it's launched a new poll.
Let me see if I can do this. I say yes, and then there.
Oh yeah, now we got it.
Okay.
Now we're cooking with butter. Yes, we
Thanks,
should.
Jen.
Not really sure. Or this is a terrible idea.
I think that's the poll from last time.
There should be a new one now where you can re-participate. It's A, B, or C. Are you seeing it?
Maybe it's just me. My Zoom has been acting funny, which is why I turned my camera off. It's my poll says understanding of medications, A, B, C, or D.
So does mine, Jen.
Oh, for weird. Well, let's end this one and see if we can see results and move on to the next one. And if not, we'll go old school and you can either share in the chat or just think in your head. So it looks like A and B are the responses I'm seeing. It was about 50-50 people thought, of course, or they were unsure. Okay, so we'll go to the next question. So babies born to individuals taking medications for opioid use disorder like methadone or buprenorphine are born addicted. Can you relaunch a new one? And if it's too much of a hassle, we can just skip the polling. Oh,
So I
there we
think
go.
what happened is you can use this poll and just put A, B, or C, or D. You see it, but just ignore the understanding of medication. So it's kind of general, but we didn't end up changing that title is what I think happened. That makes sense. Thank
There
you.
we go. Perfect. All right. So it looks like we're getting some good responses. You can go ahead and end it and share it. So a mix on this one about whether or not babies are born addicted, kind of across the board. So we'll talk about that. And then finally, individuals should stop taking medications for opioid use disorder. And if you want to relaunch that same generic poll, when should people stop?
Okay, thanks.
Thanks for bearing with us for those who are having polling issues. All right, you can go ahead and end that one and share it. Looks like mostly a mix of C and D with a little bit of B on that one. Okay. Yeah. To stop sharing my screen to get this polling thing out of the way again. Good grief. Sorry, people. Thanks for hanging in there. All right, so mostly said within 2 years or never, but one with a 12 months. We'll talk about that. So can we use medications for opioid use disorder in pregnancy? And the answer is emphatically yes, absolutely, we can. And there are benefits for both the mom or the pregnant individual and the fetus. So it reduces overdose and overdose death, decreases risk of infection, and increases engagement in prenatal care and recovery treatment, which is huge, right? Reducing death, right? Benefits for the fetus is reducing the highs and lows of opioid levels and reducing fetal stress if there are ongoing opioid use outside of the medication, decreases loss of the fetus and preterm delivery. So absolutely, medications for opioid use disorder can be safely used in pregnancy, both methadone and buprenorphine. And are babies born addicted? No. So here's a really important education point that you all hopefully can take away from here. They're born dependent, not addicted, right? Because they're not having compulsive drug use and use despite harmful consequences. They're having dependence in terms of they've had that medication present, so they may have withdrawal when they're first delivered, which can be managed. So babies are not born addicted. Babies can be born dependent. And that's not just for opioids. As example, like if mom's using tobacco, if mom's using certain antidepressants and things that are very important to her health, there can be some withdrawal and some side effects in the newborn, but that's very manageable and absolutely worth it for the health of the mother so that they can have a healthy pregnancy and delivery. One other thing I wanted to mention about this, two things actually, that are misconceptions is I've had pregnant individuals that want to reduce or taper their dose of their methadone or their buprenorphine, thinking that that will reduce the risk that their baby will have withdrawal when they're born. You may have heard of NAS or neonatal abstinence syndrome, and we're moving away from that language toward neonatal withdrawal symptoms or syndrome. But there's not a direct connection between the dose of methadone or the dose of buprenorphine and the likelihood or the severity of withdrawal in the infant. So I'm going to repeat that. There's not a direct relationship between the dose the mom is taking and whether or not the newborn will experience withdrawal or the intensity of that withdrawal. So the best dose for the mom is the dose that keeps her stable. The best dose is the dose that keeps her stable and healthy and engaged in prenatal care. So I think that's just a really important point. That of course, if they want to adjust their dose, we would do that in consultation with them, but it's not recommended. And in fact, because of the changes to the body in pregnancy, often we'll see that individuals will need an increased dose of methadone in particular, or maybe even split dosing for them to have a stable level while they're pregnant. Should people taper off? It's really not the goal, and we were a little bit mixed on this. This is a chronic disease of the brain. There is no evidence that says there's only a certain amount of time you should be on this. Just like same with other medications for chronic conditions, right? It may be lifelong. There are behavioral interventions that can and recovery supports that can help people feel maybe like, okay, I want to try going off or I want to taper my dose, and certainly we would support them. But when people do taper off these medications, it is possible to have a return to use or an overdose as well. So, everyone has that one patient they, felt like was super stable, a lot of support in place, was ready to go off, and then they went off and then had an overdose, right? So just that one person makes you nervous too, but it really is individualized what that person has for supports and what they have for their own desires. So we never mandate or expect somebody to go off treatment, but we support it if that's part of their long-term goals as well. So I think that's important to note, because I think early on in particular, we saw programs where people would get started, but they could only be on it for a couple of weeks, or it was really only managing acute withdrawal, and then the meds were taken away, or you could be on it for 3 months or 12 months, and that is not evidence-based. It's really an individualized approach. And there's no expected duration. It can be lifelong, which is why we want to make sure we're having those conversations with people before we start too, right? That this is a medication you may be on long-term to help you be stable, so that they're aware of that as well, since it could be long-term for them. Want to make sure that they have the information they need to make those choices for themselves. And you heard Kat mention abuse or misuse of medications for opioid use disorder. You know, it happens. We know it happens. We hear it happens. Maybe some diversion where someone gives or sells their medication to somebody else. And what we hear is often it's altruistic. So, you know, I went to the clinic, I got, you know, my Suboxone, but my significant other is in withdrawal. So I split the Suboxone with them to try to help them with their withdrawal as an example. And so it's difficult to really identify the true rates of this type of diversion and how harmful it is. I don't think we have data, but anecdotally, so again, I don't have data to support this, want to be clear, but from what we hear, it's not that people are often using for the first time with one of these medications for opioid use disorder. Usually what we hear is more helping people get out of withdrawal from another substance is why it's being diverted or sold. So I guess I'll leave it at that. And just that there are a lot of strategies to try to minimize that misuse, like limiting the amounts that individuals get. Certainly people that take methadone, there's federal regulations around how many take homes people can get over time and things like that, doing pill or film counts to make sure people have the right amount, and doing urine drug screens to make sure that the drug is actually in the urine and they're the person taking it. So on the one hand, that can help deter diversion. On the flip side, for people who are really, you know, stable, doing well, et cetera, it can feel really punitive and stigmatizing to have these sort of restrictions on their medication over time too. So how do you strike that balance of taking care of individuals, giving them access to what they need while keeping the community safe as well? So those are some things we struggle with, but definitely there are strategies to try to avoid misuse and diversion of these medications. Always want to mention that we do have an opioid reversal agent called naloxone or Narcan. There's a nasal spray version and then there's an injectable version as well. And anybody taking opioids, prescription or otherwise, or at risk, they or their family member or roommate, whoever, should have naloxone available to them and be trained on how to use it. And it works by sitting on that same receptor, kicking the opioid off, and that allows the person to breathe. Because when you get too much, when you have that overdose, what happens is your breathing slows down and eventually stops. So this can reverse that. And then I also want to note, you know, people get frustrated. Well, you know, we reversed their overdose with naloxone and they went straight back to use. Well, yeah, because they felt like they were dying because they were in significant withdrawal. So if you understand how it works and how terrible someone feels, it makes sense why we're trying to get more low barrier access to medication for opioid use disorder, so we can help people feel stabilized and not need to go out and use on the street, because there are a lot more risks to that and not knowing what's in the drug supply. And I guess I'll just make a comment about that as well. You know, we've seen a lot of the drug supply contaminated now with fentanyl or fentanyl analogs or synthetic fentanyl-like drugs that are more potent. Some people now are just using fentanyl and have developed a tolerance to that. The other thing that we're seeing, not so much locally here yet, but nationally I'm hearing about it, is this xylazine or tranq, which is a veterinary sedative. And it is not reversible by naloxone or Narcan. So that can be problematic for people as well. So I think, you know, if we can get people using a medication that we know what it is and they can take it regularly, that's going to be a lot safer for them than using what's being sold out on the street. So how do we contribute to stigma? We talked a little bit already about language. I think the other thing we can do to help destigmatize and bust myths is to really know that, why do we use medications? Why do we substitute, I say in quotes, one medication for another? Because the evidence is very clear that it reduces death, criminal activity, infectious disease, which can cause a lot of illness and death as well, like heart infections or hepatitis, as an example, hepatitis C. And it saves us all money. There's actually a return on investment. So for folks that maybe still are feeling biased or aren't wanting to help folks with opioid use disorder, it actually saves us as a community money if we help people with the appropriate treatment so they can function and have higher quality of life and engage in other services that might support their quality of life. This is an Institute for Healthcare Improvement table, and I think you can probably find these other places as well, but recover, hope, and stop talking dirty. So again, trying to use person first language, not using dirty and clean, those types of things, return to use, talking about urine drug screens, things like that. not using stigmatizing language, talking about individuals and using more person first language. And so would welcome any ideas you all have around that as well. So I'm gonna, my contact information is here if you have follow-up questions, concerns, or experiences to share, but I really just wanna stop share and take our last few minutes here to answer any questions that you might have, or any contrary things you've learned, or ideas that have been helpful for you in your roles. So you can chat in or unmute. We'd be glad to hear from you. And I don't know, Mary Jo, too, if you had any questions or anything I missed that you wanted to bring up. I know we have an evaluation, so we'll put that link in the chat. We really value your input. So yeah, I see you already put it in there. So
I just did that, yes.
Thank you. Yeah, we always try to improve them, and we want to know how we're doing. So please complete the evaluation.
The only thing I would say is that I will put in the chat our website, because Carrie has some really great videos on, kind of breaking down some of the things that she shared today around what is addiction, what are opioids, and those kind of things. And so I will put that in the chat here. But I really appreciate, Carrie, this discussion today and all that you share. I always learn something every time I listen, but even, keeping us up to date on the different things that are out there, like fentanyl, like what was the veterinary?
Xylazine, I can put it in the chat.
Yes, I just heard about that on our local public radio, our state public radio. But just, it's such an evolving thing, so much evolving around just different substances and what they are and what they mean and what they can do and how we can help. And so I think just being on top of that and staying relevant is so important. So thank you for adding those in.
Yeah, you bet. Other experiences or ideas folks have to share? This has been a really quiet group. I usually have some people telling me that they're disagreeing or they've seen something else, or what about this instance or that instance?
I just have learned so much. I mean, honestly, I have. Thank you so much.
Well, you're very welcome. I'm glad. And if you have other ideas of how we can get this information out, would welcome that as well. Sometimes I'm not sure what services you work in. I don't know, Jen, where you're from, but I've given presentations and then had people say, hey, you should talk with these housing folks, or you should talk with these folks, because they've heard some misinformation. So we certainly want to make sure we can provide resources to people that are helpful.
Well, we're going to take this recording and blast it out to so many people. You're going to be like internet famous, Carrie. You're going to be like, oh no, people know me too much.
And I see Janine put in the chat that, I think judges need to have the information. Absolutely. And I think there's a lot of intersection with the criminal justice system, and how can we all support each other to get the outcomes we're looking for. So I'm fortunate in our Duluth area, we do have judges that are very involved in this work and really working to help people get what they actually need to have healthy quality of life and move forward. So absolutely. Good point. Thank you. All right. Well, I would just again want to thank everybody for being here. Please complete the evaluation, and I'll just hang out for a few minutes too. If anybody wants to stand, if you just want to ask a one-to-one or smaller group question, I'm happy to try to answer that as well. So thank you so much again. Have a good rest of your day.
Maybe we should stop